It's actually quite startling when you think about it, but something like two-thirds of adults here in the UK have cholesterol levels that are, well, higher than recommended.
Over that 5.2 millimole mark, it really makes you think.
It does. And today, we're diving into one specific reason for that really high cholesterol: familial hypercholesterolemia, FH for short.
Exactly. And FH isn't just, slightly high cholesterol. It's different. It's genetic.
Inherited.
Yeah, passed down. And it means you have really high levels of the bad LDL cholesterol right from when you're born, pretty much.
Wow, from birth.
Yes. And that early constant high level really ramps up the risk of heart disease, much younger than you'd normally expect.
So catching it early must be crucial then.
Oh, absolutely life-changing. Spotting FH early means you can manage it and change that trajectory.
Right. So we've got some notes here looking at FH from all angles: what it is, the genetics behind it, who's most at risk, how it's diagnosed, managed. The whole picture.
Yep, the
Yeah.
key stuff.
And our mission today is basically to pull out the absolute must-know information about FH so you can understand why it's important, maybe for you or for your family.
Let's do it.
Okay, so let's start with the definition. How do we actually define FH here in the UK?
So the UK definition is pretty straightforward. It's an inherited genetic disorder. Key things are high LDL cholesterol and a predisposition to early cardiovascular disease. Simple as that.
Okay, but you hear other terms thrown around like hyperlipidemia?
Right, good point. It's easy to get them mixed up. So hyperlipidemia is broader, just high levels of fats or lipids in the blood. Could be total cholesterol, LDL, triglycerides.
And dyslipidemia.
Even broader, that just means any abnormal lipid levels. So
Yeah.
that could even include low levels of the good HDL cholesterol. And hyperlipidemia is basically another general term for high blood fats.
I see. So the familial bit in familial hypercholesterolemia is the absolute key, the genetic part.
Precisely. It's about the inheritance. FH is usually autosomal dominant, meaning if just one parent has the faulty gene, there's a 50% chance each child will inherit it. It all comes down to the liver not being able to clear out LDL cholesterol properly because of a gene fault.
Okay, and which genes are we talking about usually?
The main one, the most common culprit, is the LDLR gene. That's the gene that tells the body how to make LDL receptors.
The docking stations on the liver cells.
Exactly. They grab LDL from the blood. But you can also have mutations in the APOB gene.
What does that do?
APOB makes a protein that the LDL particle needs to actually bind to the receptor. Think of it like the key fitting into the lock, the receptor being a lock.
Right.
Or, less commonly, the PCSK9 gene. That one sort of controls how many LDL receptors are actually available on the liver cell surface.
So different ways the system can break down genetically.
Yeah, but the end result is the same. The liver's cholesterol clearing system is faulty.
Got it. So these genetic issues lead to high LDL. How does that actually, cause heart problems down the line?
It's a direct link, really. Because the LDL cholesterol isn't cleared properly, it just builds up and up in the blood, persistently high.
Okay.
And that excess LDL then starts getting deposited in the walls of your arteries. Over time, this forms those fatty plaques, atherosclerosis.
Narrowing the artery.
Exactly. It narrows them, restricts blood flow, and makes blood clots much more likely. And that's what leads to heart attacks, strokes.
So even if someone has a healthy lifestyle.
Lifestyle always matters for heart health, definitely. But with FH, the primary driver, the big problem, is that underlying genetic defect causing sky-high LDL from the start. Diet and exercise help, but they often can't overcome the genetic issue alone.
Okay, that makes sense. So thinking about risk, who really needs to be aware of FH?
Family history is the huge red flag.
Yeah.
If you have close relatives, parents, siblings, children who had heart disease young.
How young are we talking?
Think heart attack, angina, stroke, needing bypass surgery or stents before age 60. That's a major sign.
Okay, before 60 in a close relative?
Yeah. Also, consanguinity parents being related can up the chances. And certain gene mutations are more common in some ethnic groups, too.
What about the usual suspects, like smoking, diet, being overweight? Do they play a role in FH risk?
They don't cause FH because FH is genetic, but they absolutely make things worse. If you already have FH with very high LDL, things like smoking or a poor diet will accelerate that artery damage, the atherosclerosis.
Like pouring fuel on the fire.
Exactly that. It speeds everything up. And what's worrying is how common FH is, yet how many people don't know they have it.
What are the numbers, roughly?
For heterozygous FH that's inheriting one faulty gene, it's estimated around 1 in 250, maybe up to 1 in 500 people in the UK, but loads are undiagnosed.
1 in 250. That's really quite common.
It is. Homozygous FH, two faulty genes, is much, much rarer, maybe 1 in a million, but it's incredibly severe, causing problems very early on.
Right. So apart from family history, are there any physical signs, things someone might actually see or feel?
Yes, there are a couple of classic signs to look out for. Tendon xanthomas are a big one.
What are they exactly?
They're cholesterol deposits that build up in tendons. Most often you see them on the Achilles tendon at the back of the heel, or sometimes on the tendons over the knuckles or elbows.
What do they feel like?
Like hard, sort of firm or rubbery lumps under the skin. They usually appear after age 20 in heterozygous FH, but much earlier, even in childhood, in the homozygous form. Finding a hard, fibrous nodule there, that's a significant clue.
Okay. Tendon xanthomas. What else?
Xanthelasmas. These are yellowish patches of cholesterol deposits on the eyelids, often near the inner corner of the eye.
I think I've seen those.
You might have. They're quite distinctive. But, important point, you can get xanthelasmas without having FH. They're less specific than tendon xanthomas.
Anything else?
Sometimes a premature corneal arcus, that's a grayish-white ring around the colored part of the eye, the iris. Usually it's seen in older people, so if it appears in someone younger, say under 45, it could be linked to high cholesterol, including FH.
Okay. So if someone sees these signs or has that family history, what happens next? Are there official guidelines for doctors?
Yes, definitely. Nice. The National Institute for Health and Care Excellence has guidelines. They recommend considering referral for specialist assessment and possibly genetic testing if an adult's total cholesterol is consistently high, say above 7.5 millimol.
7.5, okay.
Or even with lower cholesterol if they have that strong family history of early heart disease we talked about. Measuring total and especially LDL cholesterol is obviously step one.
And how is the diagnosis actually confirmed?
Doctors often use clinical scoring systems. The main ones are the Simon-Broom criteria and the Dutch Lipid Clinic Network, or DLCN, criteria.
What do they involve?
They combine things like the actual cholesterol levels, especially LDL, the family history details, whether those physical signs like xanthomas are present, and sometimes DNA test results, if available. It gives a score indicating the likelihood of FH.
So it's putting all the pieces together.
Exactly. And if FH is diagnosed or highly suspected, the person should be referred to a lipid specialist. And really importantly, cascade testing should be offered.
Cascade testing.
That means systematically offering testing to the patient's first-degree relatives, parents, siblings, children, because they have that 50% chance of having FH too. It's the best way to find other affected family members early.
That makes perfect sense. Find one case, look for others in the family.
Crucial for prevention.
So once someone gets that FH diagnosis, what's the plan? How is it managed?
The absolute main goal is to hammer down that LDL cholesterol level, really aggressively lower it to cut that high cardiovascular risk.
How do you do that?
It's usually a two-pronged attack,
Yeah.
lifestyle changes and medication.
Lifestyle first.
Well, yes, important baseline stuff. Heart-healthy diet, low in saturated fat, regular exercise, definitely stopping smoking if they smoke, all crucial.
But you said lifestyle often isn't enough on its own.
That's right. Because the genetic drive for high cholesterol is so strong in FH, medication is almost always needed. Statins are the cornerstone.
Which ones?
Usually high-intensity statins, they work well to reduce the amount of cholesterol the liver makes. The aim is often a big drop in LDL, ideally 50% or more from the starting level.
And if statins aren't enough or cause side effects?
Then other things can be added. Ezetimibe is common. It reduces cholesterol absorption from your food in the gut.
Yeah.
And for very severe cases, maybe homozygous FH or people who just don't reach their LDL target despite statins and ezetimibe, there are more advanced options.
Such as?
Things like LDL apheresis, that's a bit like dialysis. It physically filters LDL cholesterol out of the blood. Or newer injectable drugs called PCSK9 inhibitors. They're very effective at helping the liver clear more LDL.
Wow, quite a few options then.
Yes, the toolbox has expanded. But the key is early detection through that family screening and genetic testing, so treatment can start promptly. While we monitor triglycerides too, the laser focus in FH management is really on LDL reduction.
So if someone is diagnosed early, gets on the right treatment, sticks with it, what's the outlook?
It's actually very positive now. With early, effective treatment, the prognosis is massively improved. Many people with FH can live a pretty much normal lifespan.
Really? despite the high genetic risk.
Yes, because we can drastically lower that LDL cholesterol and reduce the risk of those early heart attacks and strokes.
Mm-hmm.
It makes a huge difference compared to leaving it untreated.
And untreated.
Untreated, the outlook isn't great. Men with heterozygous FH have a very high risk, maybe 50% chance of coronary heart disease by age 50. For women, it's a high risk by age 60.
That's stark.
It is. And for homozygous FH, untreated, it often leads to severe heart disease and even death in childhood or early adulthood. Treatment is absolutely essential.
Okay. Now, you mentioned FH is genetic. Are there other conditions that cause high cholesterol that might get confused with it? A differential diagnosis?
Yeah, absolutely. Need to rule out other things. There's familial combined hyperlipidemia, or FCHL. That's also genetic, but it tends to cause high cholesterol and high triglycerides, and the LDL isn't usually quite as sky high as in classic FH.
Okay, FCHL.
Mm-hmm.
Anything else?
Polygenic hypercholesterolemia. That's more common. It's not one single faulty gene, but the effect of many different genes combined with lifestyle factors leading to high cholesterol.
So more complex inheritance.
Exactly. And then you've always got to consider secondary causes.
Things caused by something else.
Right, like an underactive thyroid gland hyperthyroidism, or certain kidney diseases like nephrotic syndrome. Even some medications can push cholesterol up, so you need to check for those too.
How do you tell them apart?
It involves looking carefully at the pattern of lipids. Is it just very high LDL, or are triglycerides high too? Mm-hmm. The family history details are vital. Those physical signs like tendon xanthomas strongly point towards FH. And genetic testing can really nail the FH diagnosis.
Got it. And if FH isn't managed, what are the specific long-term problems, the complications?
The big one, the main complication, is premature atherosclerotic cardiovascular disease.
That's the umbrella term.
Yes, covering things like coronary artery disease leading to angina, heart attacks.
Myocardial infarction.
Exactly. Stroke is another major risk. And peripheral vascular disease affecting blood flow to the legs. It all stems from that accelerated plaque buildup in the arteries.
So the key message is treat it early to avoid all that.
Absolutely. Early intervention prevents or significantly delays these serious, potentially life-threatening complications.
Okay. So if someone is concerned, maybe it's the family history, maybe a cholesterol test result, what are the first tests a doctor is likely to run? The investigations.
First step is always a full lipid profile blood test. That measures total cholesterol, LDL, HDL, and triglycerides. LDL is often reported as non-HDL cholesterol these days, which is also very useful.
Standard blood tests.
Yep. Then you'd usually do tests to rule out those secondary causes we mentioned.
Like the thyroid check.
Right. TSH for thyroid function, HbA1c to check for diabetes or prediabetes, kidney function tests, electrolytes, liver function tests, LFTs. Just basic checks to make sure something else isn't causing the high cholesterol.
And then potentially the genetic testing.
Yes. If the clinical picture, high LDL, family history, maybe physical signs strongly suggests FH based on those criteria like Simon Broom or DLCN, then DNA testing is usually offered. It confirms the diagnosis and is super helpful for that cascade testing in the family.
What about children, if a parent has FH?
There are specific guidelines. If you know the exact gene mutation in the affected parent, you can test the child for that specific mutation. If not, you'd typically measure their LDL cholesterol levels. Sometimes this needs repeating after puberty, as hormones can affect levels.
Right, that's really comprehensive. Okay, let's try and boil this down. Key takeaways for our listeners. High yield points, maybe.
Okay, key things to remember. FH is genetic, causes very high LDL cholesterol from a young age, and seriously increases early heart disease risk. That's the problem.
But the solution?
The solution is early diagnosis, look for family history clues, check cholesterol, be aware of signs like xanthomas, and then aggressive treatment, mainly with statins and other meds, works incredibly well.
And makes a massive difference to long-term health.
Huge difference. Can lead to a normal life expectancy if managed properly from early on.
So the message is really, if this rings any bells, the family history. High cholesterol results, especially over that 7.5 mark, or relatives having heart problems before 60, talk to your doctor.
Definitely. Don't ignore it. Ask the question.
Given how common FH seems to be, maybe 1 in 250, but often missed.
Yeah, it really makes you think, doesn't it? It poses that question for everyone listening. How well do you know your family's heart health history? And what steps could you or your family take to be a bit more proactive about understanding those risks?
Something definitely worth pondering.
Absolutely. Know your numbers, know your history.
Great advice. And for anyone wanting more info, perhaps especially those revising for exams like the MSRA, you can check out resources at passthemsra.com. and freemsSRA.com.
Good resources there.